Welcome to American Medicine Today. I'm Kimberly Bonati alongside Ethan Youker. We have an exciting show lined up. We're going to get right to it. So researchers from around the globe have worked together to develop a blood test that makes it possible to predict the diagnosis of Parkinson's disease in at-risk patients up to 7 years before the onset of typical motor symptoms. Joining us to discuss is Dr. Brit Mollenhauer, neurologist with the University Medical Center in Germany. Thank you for joining us.
Thank you for having me.
Certainly. So first off, why don't you tell us how Parkinson's disease progresses over time?
It is a progressing disease. Over the years, it progresses towards motor symptoms like tremor or stiffness, sometimes even cognitive impairment.
Do we know how Parkinson's develops? Is it genetic or do we not know?
It's probably multifactorial. We really don't know everything, but we do know that there are some risk factors like pesticides and herbicides, maybe also viruses or head traumas. We do know that diabetic patients have a higher risk to develop Parkinson's disease, so things like that. But there's also about 10% are genetically determined, but not 100%.
And what about the role that dopamine plays in the brain as far as the motor symptoms?
So what happens in Parkinson's disease is that due to the aggregation of alpha-synuclein, which is a protein in cells, the dopamine cannot release from the cells to the second neuron. So we do have de facto a dopaminergic deficit. And that causes these motor symptoms. It does evolve over many times. So we do think that Parkinson's disease starts about 20 or even 30 years before the onset of these motor symptoms.
What was the goal? What specifically were you looking for?
So the problem we are facing is that we do have symptomatic therapy to replace this dopaminergic deficit. We do have that, but we do not have a medication to really stop the progression of the disease. So it can really be at a stage very devastating with these motor symptoms. And again, I said sometimes it's cognitive decline, which also appears. So the problem is that we may actually have medication that could stop the disease, but we cannot show the effect. This is why we look for biomarkers to support clinical trials with this medication. And something else is important. We do think that when we start 20 years after the onset of the disease, when there is already the tremor or the rigidity, it may be too late. So we need biomarkers for clinical trials to then also go much earlier, maybe to prevent the disease.
You say that AI as well as these blood samples are utilized in detecting Parkinson's. Why is it that we're not just using it for the general population and it's only for those at risk for now?
I mean, it's a very first step. It needs validation in independent cohorts, and it does need still a lot of work. And it's primarily maybe right now more to eventually support clinical trials to identify subjects at risk and also to understand maybe the molecular pathology better because it identified a few pathways that are interesting.
And so where does that number of 7, because that's kind of what caught my attention, is that with this test, you can potentially detect 7 years in advance someone who might eventually develop Parkinson's disease. I mean, how do you determine that number, I guess?
Yeah, so what we had utilized in the first instance was really clearly defined Parkinson's disease patients and healthy controls. And then we looked into subjects where we do know they have a much higher risk to develop Parkinson's disease. So these have isolated REM sleep behavior disorder. This is a condition where you act out of your dreaming. And so these subjects are at a very high risk to develop Parkinson's disease. And we have cohorts with these subjects who have not PD, but REM sleep behavior disorder. And we follow them every 2 years. So we had a cohort of those subjects and had some patients who developed Parkinson's disease. And in this cohort, we had some subjects with this dream enactment behavior that were before they developed Parkinson's disease. So the blood protein panel looked like PD in some of those subjects 7 years before they were diagnosed with Parkinson's disease.
And so what does it mean if you're able to treat the disease I'm going to assume getting that type of diagnosis first with treatment will ward off those symptoms at least for a long time.
Right. So we do know once these motor symptoms show with the tremor and the stiffness, we do know that about 70% of these dopaminergic neurons that I was talking earlier about are already degenerated. So we think that at that time, a causative treatment stopping this from progressing further might just be too late. And therefore, we think when there are still more neurons that are still vital and can still produce dopamine, that we should really treat Parkinson's disease that early.
And what's next for this research, and when will it be more broadly available?
And we are moving into a population-based cohort that we have built in our town castle here, where we ask the population to fill out risk questionnaires on symptoms that occur before the onset of motor Parkinson's, like this dream enactment behavior, but also hyposmia. And so we do have a population-based cohort where we already took blood, and this is the next step for us.
And where can people learn more?
I mean, the Michael J. Fox Foundation is doing so much, but also other foundations and other sources. I mean, I'm just very happy that this is picked up by media so well. I think it's a very important thing to bring Parkinson's disease to the attention. It's an age-dependent disease. It's not a disease that mid-agers talk about, but it's a disease that we need to talk about because it starts in the mid-ages.
And at least people know what's on the horizon as far as being able to detect it first and get the important help that they need. Thank you so much for being on the program, Dr. Brit Mollenhauer. Thank you for joining us on the show.
Thanks for the invitation.
Make sure you stay tuned. We'll have more after the break. You are watching American Medicine Today.
The loss of coordination in my legs, I'd trip over my feet, end up flat in the concrete. Dr. Bonati to me was God sent. Look like that in a while. I don't remember how long. I didn't have to make a massive lifestyle change. I noticed today that I could sit and stand up without a cane. I would have to give it excellent and above my expectations.
Visit AskBonati.com. Donald Sparkman is an extraordinary entrepreneur.
I've been a self-made man. I've never worked for anybody at all. My whole entire life, I've always been self-employed, never had a paycheck. Worked most of my life moving houses and barbering. And moving houses is a really tough business, crawling underneath houses and jacking them up and putting them on trailers and moving them across town. I'd work in the barbershop during the day, and after the barbershop, I'd work on moving houses.
But a slip and fall changed everything for Don.
I was at one of my rental houses, and it had about 7 stairs going up it, and there was mildew on it, and I fell down the mildew stairs and hit my lower back on each rung of the stairs. And at that time, I did the natural thing that comes to most guys is just did that dance, you do when you get hurt. Oh my God, oh my God. A couple of days later, I couldn't walk. So I did the Bengay thing and the icy hot and the cold packs, and it just didn't get any better.
His pain intensified so much that he was no longer able to function at his normal 110%.
The pain on my body was in my lower back. It hurt so bad that I could hardly walk, and it was just pain of needles going down my right leg and sometimes my left leg. It got to where my days at the barbershop were shorter and shorter until the time that I had to start walking on a cane. So I went to my general practitioner, and that's when he took the x-rays and told me that I had several ruptured discs. The thing that I wanted to do first is go to a chiropractor, see if he could help me with those disc problems. He did nothing but hurt me. Also took several of the shots in the spine from my pain management doctor. They started giving me pain medicines that made my stomach sick. My memory was foggy. I was on a cane, couldn't do anything. I felt like half of a man. When you can't do anything, you're used to doing everything.
He knew that he had to take matters into his own hands and contacted the Bonati Spine Institute.
It was on the TV that I heard about the Institute. Then I did my research, and I had read on the internet how he had helped others and seen others that had similar back issues like mine. It wasn't hard to make my decision after reading the testimonies on the internet. So that's when I decided to go to Hudson, and I went down there and they redid an MRI, and which was made me feel good because it didn't take anybody else's opinion. They made their own opinion up. I did talk to a surgeon, and he explained everything to me, explained to me how the operation was going to take place and how long it would be, and that I would be able to be without pain any longer. It was hard to deal with. And this man was telling me he was going to give me back my life. I'm real thankful for that.
If you are considering spine surgery to relieve chronic pain, the Bonati Spine Procedures are targeted outpatient procedures, unlike anything else in the market.
I didn't still understand how this was possible, that he could just make such a small incision and this would cure the pain, but it did. And after I got off the table, I felt so good. I took my wife to Tarpon Springs and walked the docks at Tarpon Springs and took her to dinner, something that I wasn't able to do for so long.
Since his procedure, Don has picked up right where he left off before the pain, working hard and managing his businesses. He's also completed several personal projects like constructing a deck at his home, refurbishing a salvage pool, and restoring a 1979 Volkswagen bus named Benny.
Well, my wife had to slow me down because I was back on my feet again, and I felt like I could do anything. But I was real lucky I could go back and do the things I wanted to do. Soon after the operation, and I didn't have any more pain, so it's kind of hard to take instructions, even from the doctor, not to do things that you feel so good to do. So I started immediately doing all those things, and I have never looked back since.
In fact, within a month of his visit to Bonati, Don went with his son on a vacation that he'll never forget.
After the operation, I took a flight to Denver, Colorado with my son, and my son drove the truck, and we went up into the mountains and we went whitewater rafting, which was really cool. And I think the rapids were fours, which were pretty strong rapids. We zip lined around the mountains. Me being the oldest man, the 4 firemen were on the tower, and I was the first one off the tower to zip line. And so they followed the old man after that, I guess. But we all had a good time, and that was a pretty cool experience, knowing that I could do the things that I used to do when I was younger without the pain.
To see more stories of recovery just like this, search for the Bonati Spine Institute on YouTube, Rumble, Apple's App Store, Google's Play Store, Roku, and Amazon's Fire TV. Welcome back to American Medicine Today. I'm Kimberly Bonati alongside Dr. Bonati. So, Dr. Bonati, why does the spine industry continue to use spinal fusions?
I am very confused constantly the way that we are treating patients with spine problems. Those treatments are practically failing. And every time that we review literature, the combination of neck problem and back problem affect approximately 1/3 of the world population. So you can see how enormous is the amount of people that are suffering with this type of a problem. And what is amazing to me is that we constantly talk about treatments. At the Institute, we treat people and we get people better almost immediately. Or the things that we develop at the Institute are so unique that they are not in the market. And then makes me feel that if we do something so fantastic, why is not the world moving in that direction? And I see constantly more and more input towards instrumentation that is so destructive, so painful, and requires so much time to recover the patient. And the amount of patients that they recover is only 40%. We recover 90% of the patients in a week. So the problem that I see here is what we do so well that is not being done in other place.
You're up against the device companies who are creating these products, and they know that they're ineffective. It's not about treating a patient's pain and really giving them a resolution to the problem.
You're seeing major universities with quote-unquote teachers and professors. They are in a field of experimentation because they allowed experimentation at the universities. Why these universities are so lost? Why do you see that the market of instrumentation is so powerful that can overtake the intellectual capacity of doctors to improve the conditions of the patients without this suffering?
If you remember correctly, we covered this on previous episodes of American Medicine Today, but it's the fake research and trials about fusions that were put out into public forum. And what they did is they were incomplete and put it out there where everyone's believing these manufactured trials.
We are the people that need to avoid the fraud. And if we do that, then the universities are responsible to do that. Okay, I fight constantly against the devices because I think they are unnecessary. I think they are dangerous. And I see that instead to try to reduce the damage and the pain of a patient and the expenses and the fact that they suffer these people for months, I feel now they develop another device that only can be treated to fuse the spine going through the abdomen. So if they require a general surgeon, the industry is to devise something that can help the patient, not something that it can harm the patient. And we see that the fusions is very well known that they harm the patients all the time. I take instrumentation very frequent in the practice because I know there was an unnecessary surgery, not because the surgeon is doing an unnecessary surgery. It's because they taught this surgeon that that is the only way that this patient can help or can be helped.
We're going to take a quick break. We'll be right back to continue the discussion on why the spine industry is continuing to use fusions.
I think everybody was shocked, like, really, you had surgery today? I had a drain tube. I was at my desk doing payroll for 200 employees, worked till night, got up, went to bed.
We went to the Bonati Institute, and that was the day, the turning point in my life. This type of surgery is so much more advanced, and the recovery time is so much less that it's just a no-brainer. If you've got pain, go to Bonati.
This is the honest to God truth. And was recovering, I didn't feel anything. The pain that I was suffering is gone. I can go back to work in like 3 days.
The surgeries that I had, actually, I recovered very easily from, I would say. I actually went to work the following afternoon.
That afternoon, when it was done, I actually felt so much better already.
First time I came in here was Monday, and today is Thursday. I've had 2 surgeries and am doing fantastic. I'm still in shock that I can walk. That's all within 4 days.
Bonati succeeds where others fail.
Welcome back to American Medicine Today. We're continuing our discussion on why the spine industry refuses to stop fusion surgeries. So I don't understand, isn't the direct approach the better one? Slitting somebody open from the front and having to remove organs and do something that can be very dangerous for the patient. Isn't it better to go through the back?
If I am successful in something, I want to repeat that success and improve on that success. If I do something and I fail, I don't want to touch that again because I know I did the best and didn't work not because of my skills, because what we are doing is incorrect. So common sense is not being applied here. You do fusions and you know the disaster with the fusions.
Well, 1-level fusions fail 65% of the time, and 2 to 3 level fusions fail 85% of the time.
I don't understand why that technique continue being bring to educate the new surgeons. That technique should be eliminated because the industry is corrupting the teachers, and the teachers are instructing wrong the students. So we start to see a path of behavior that is being seen in this country now in everything.
I think that's because the industry is focusing more on procedural technique versus true patient pain resolution, instead of it being more patient-centric and about results and how that is helping them achieve pain relief. Thank you for watching, and if you would like to see previous episodes of our program, you can search American Medicine Today on all your favorite streaming apps.
If you have any comments or questions, contact us at the numbers below. Or you can tweet at Dr. Bonati using the hashtag American Medicine Today or hashtag AMT. We would like to hear from you.